I am Senior Clerk John Arthur Jason De Diego, and today I will be lecturing to you the essentials to know about the rectum, the anus, and the prostate, to include the important questions to be asked in the history taking and how to go about the physical examination. Good. Let's start with the anatomy. The sigmoid colon, as we all know, terminates the rectum. The rectum lies against the sacrum and the coccyx and ends up in a short segment known as the anal canal. In this image, it shows the two different sphincters that are responsible in holding the anal canal closed. We have the internal anal sphincter and the external anal sphincter. The internal anal sphincter is an extension of the muscular part of the rectal wall. We can also see a serrated line marking the change from mucous membrane to skin, which determines the change from rectum to anal canal, known as the pectinate or dental line. In The prostate gland surrounds the urethra and lies next to the bladder, which can be palpated when doing a digital rectal exam. The prostate gland has two lobes, the right and the left lateral lobes, which is separated by a shallow median sulcus or groove, which usually disappears when the patient being examined has benign prostatic hyperplasia. For the history taking, common complaints that would lead us in doing a thorough examination of the system is when the patient complains of changes in bowel habits, blood in stool, pain with defecation, or bleeding from the anus, or pain or tenderness, the presence of warts or fissures in the area, a weak urinary stream, burning sensation while urinating, or presence of blood in the urine. We should also ask about changes in the frequency of bowel function, the size or caliber of the stools, diarrhea, constipation, or any abnormal color of the stools. These types of questions would really aid us in giving about our differential diagnosis. Say, for example, the patient complains of changes in stool caliber. This could warn us of colon cancer. Blood in the stool may point to polyps, carcinoma, or hemorrhoids. A presence of mucus may present in patients with villus adenoma, inflammatory bowel disease, or irritable bowel syndrome. Pain upon defecation or any itching or tenderness would suggest proctitis caused by gonorrhea or chlamydia, which is also important for us to ask about the patient's sexual activity. Presence of anal warts or fissures would tell you that the patient has human papillomavirus or condylomata and syphilis. And lastly, changes in the pattern of urination would suggest benign prostatic hyperplasia that would need further examination and queries to quantify severity and guide the management of that patient. This is an example of the BPH system score by the American Urological Association. A higher score indicates more severe symptoms, while a score of less than 7 is considered mild and does not require any treatment. We now then proceed to the techniques of examination. But before we start off the physical examination of the system, which includes inspection and palpation of a very sensitive area, it is important to explain well to the patient how the procedure would go and apprise them of the discomfort that they may feel and make sure to keep them relaxed to hasten the examination. However, the examination of this system is not routine. It can be omitted if there are no relevant complaints. There are two different positions in examining the rectum. First one, as shown in the image, is when the patient opts to lay on their left side and bend the knees. The second one is a much less dignified position because the patient is asked to stand up, lean forward with his upper body resting or laying across the examining table, and then the hips is flexed. Before we proceed with the examination, as physicians, we must ensure that our hands are gloves, and then we proceed. First off, we start by inspecting the perianal areas to note for any lumps, ulcers, inflammation, and rashes. By inspecting and noting any abnormalities, we can determine presence of either hemorrhoids, warts, herpes, chancres, and tears that could give us differentials. There are two. We then gently examine the anal canal and the rectum by palpation. First, we lubricate our index finger with a KY jelly and proceed by placing the pad of our finger or our index finger over the anus to relax the sphincter. Slowly, we insert the fingertip into the anal canal, and if the sphincter tightens, we must stop the procedure and assure the patient to relax. One must not roughly insert the finger when the sphincters are contracted. If the patient complains of tenderness that prevents entry, it is important to not apply force. Thus, let the patient bear down and slowly inspect the area. In palpating the rectal surface, we try to reach our index finger as far as we can and rotate our hand to be able to palpate as much of the surface. Any nodes or irregularities should then be noted, which I will be showing in the next slide. As I have mentioned, here in this image, we show how the index fingers try to reach as much as they can and rotate or palpate all surface of the rectum to note for any nodes or irregularities. Then for the males, the prostate gland is palpated by rotating the pad of the index finger facing the scrotum area and trying to palpate the posterior surface of the gland. As much as possible, we try to feel if it is enlarged or if the median sulcus, as mentioned, of the prostate is present. After examining the prostate, we then withdraw our examining finger. Upon doing this, we note for any fecal material on the glove to see if mucus or bleeding is present. Then for the females, usually the rectum is examined after the female genitalia when the patient is in a dorsal lithotomy position. This allows the physician to perform a bimanual examination. If a rectal examination is thoroughly needed, the position and flow of examination is same with that of the males.
Gathering together your equipment, you're probably pleased to know that this is not an ANTT procedure. You will need gauze or tissue, non-sterile gloves, and some form of lubrication. In real life, we obviously use a water-based gel such as KY or aqua jelly, but in an endoscopy station, because of the models, we tend to use silicone oil. Ask the patient to lie on their left-hand side on the edge of the bed with the knees brought up towards the chest. Wash your hands using Alka-Gel and put a pair of gloves on. Make sure there's a good light source and start your inspection. Inspect around the perianal area and explain to the examiner that you're looking for things such as hemorrhoids, fistulas, lesions, warts, and the general cleanliness of the area itself. Ask the patient to strain or bear down and explain to the examiner that you're looking for any signs of a prolapse where you would expect the pink mucosa to start showing through. So, going on to palpate, lubricate your index finger, place your finger down the natal cleft onto the anal margin. Ask the patient to relax and take a deep breath in. As the sphincter relaxes, advance your finger into the anal canal. Check the sphincter tone by asking the patient to squeeze your finger using their anal muscles. Rotate your finger through 360 degrees, feeling for thickening and masses. Warn the patient that you're about to insert your finger deeper into the rectum, and then repeat your 360 degree sweep again feeling for thickening, masses, and noting any feces there. Prostate examination. Obviously, only perform this to male patients. Warn them what you're about to do. You should be able to feel the prostate through the anterior rectal wall, and you should be able to identify the two lobes either side. They should feel slightly rubbery. You should be able to identify central sulcus. If there are any masses there, describe them in the usual way. Finally, warm the patient and then gently withdraw your finger. Inspect your glove for blood, mucus, feces, and possibly any pus that's there, and tell the patient the examination is now over. Offer to wipe them or let them wipe themselves. Remove your gloves and wash your hands, and explain to the examiner any further examinations or investigations that you would perform at this point. So to summarise,
These are examples of abnormal findings that we may commonly encounter when doing our examination. This is how hemorrhoids would look like. It may be external, internal, or there is a total prolapse of the rectum. Anal fissures would present as an ulceration of the anal canal, usually found in the midline. Polyps are also palpable upon examination. When noted, it would then tell us to ask for a biopsy to determine malignancy. And lastly, abnormalities of the prostate would present upon palpation. Enlargement would tell us the presence of benign prostatic hyperplasia. Hardness of the gland would say it's a cancer, and tenderness and swollen and warm gland accompanied by systemic infection symptoms such as fever would lead us to think of prostatitis. That is all for my presentation about the physical examination and history of the anus, the rectum, and the prostate. Thank you and have a good day ahead. All images and text were lifted from Bates' Guide to Physical Examination and History Taking 12th edition, and the video I showed earlier was from the YouTube, which was entitled Rectal Exam by Nick Smith, produced last 2010. That's all for my report this day. Thank you.